internal os. And then we have a vasa previa, and this is where a fetal vessel lies over the cervix. Again, not technically the traditional previa, but we still add that in there as well. Next question. What should you not do when a patient has a placental previa? We'll probably go over this a couple times during these lectures. Do not do a vaginal exam. Why not? Well, because if you're going to be poking right into that placenta, you're going to maybe even cause a hole. You can cause a lot more profuse bleeding. So just keep your hands out of the vagina when there's a placental previa. Next question. A 26-year-old pregnant patient at 36 weeks gestational age presents with painless vaginal bleeding. An ultrasound confirms placenta previa. She continues to have significant bleeding, and her vital signs show mild tachycardia. What labs are important in this situation? So, because this patient has significant bleeding, which could be life-threatening, she will most likely require an immediate C-section. So you'll want to look for signs of severe blood loss and signs of DIC. So the baby is already 36 weeks old, and you're not really that concerned about fetal lung maturity at this point, so hopefully you have good dates. So you probably wouldn't have time to check any of this stuff anyway. So at this point, you're basically just trying to keep the mom alive so you can get the baby out and keep the baby healthy as well. So the C-section really needs to occur very, very quickly. So what test do you specifically want to do? Well, you want to check a CBC. You want to look for any major blood loss. Maybe they need to be transfused. You want to look for signs of DIC. So you're going to check your PT, your PTT. You're going to check a D-dimer. You also can check fibrinogen. You want to type and cross as well. And why would you want to do that? Well, in case this patient needs a transfusion. And then you can also do one of the KB stains as well, and that'll also help you if mom has Rh negative status, whether or not they're going to need RhoGAM. And we'll talk about that in the next question. So the next question, why do we check a Klauhauer-Bethke sign with placental previa? So we're checking the KB test for fetal-maternal transfusion. So you're seeing if there's any blood that came from the baby that is now in the circulation of the mom. So why would that be bad? Well, if mom is Rh negative and the baby is Rh positive, then potentially you could have problems with the next child with incompatibility problems. So what do we use in that situation? Well, in an Rh negative mom, we're going to want to use RhoGAM. Now, hopefully, if this patient has gone through the good prenatal screening, RhoGAM's been given at the appropriate time anyway, but you always want to check all this stuff because people don't always do what they're supposed to do, and even doctors too. Next question. A 22-year-old pregnant patient at 20 weeks gestation has an ultrasound which shows the placenta covering the cervical os. What is the next step in management of this patient? So this is a good trick question. The answer is nothing. So how far is this patient along? Only 20 weeks. So this is very early on in pregnancy. Placenta previa can only be diagnosed in the 3rd trimester. So it's not uncommon for the placenta to be covering the cervical os early in pregnancy. And as the pregnancy progresses and the uterus enlarges, the placenta will most likely migrate off of the os into a more normal position. So don't be worried you're going to get that early ultrasound and maybe it'll say, placenta over the os, and you go, oh my gosh, what do we do? And the answer is nothing. So just keep doing what you're doing. All right, so that's going to end our quick review. Let's get back to the lecture.
Placental abruption is another significant cause of 3rd or antepartum hemorrhage. 30% of 3rd trimester hemorrhage is caused by placental abruption. This is defined as premature separation of the normally implanted placenta from the uterine wall. We really don't know what the cause of this is, but we know there are a lot of predisposing and precipitating factors. Hypertension is a big one. Previous placental abruption puts the patient at risk for having this recur. Multiparity, uterine distension, multiple pregnancy, polyhydramnios where there's excess amniotic fluid, vascular deficiency, diabetes mellitus, collagen vascular diseases, cocaine use. I trained in Kansas City in the mid-90s, and cocaine use was huge then. We saw a lot of abruptions with women coming in high on crack cocaine. Cigarette smoking is another risk factor, and alcohol use of greater than 14 drinks per week. The circumvallate placenta, as I noted before, and the short umbilical cord, because with fetal movement they're constantly tugging on that cord and can pull the placenta away from the wall of the uterus. Other precipitating factors, trauma, which can be from external or internal version, motor vehicle accidents, abdominal trauma of any cause, any sudden uterine volume loss, such as delivery of the first twin. Once you deliver that first baby, the uterus is already trying to contract down and can shear the placenta. Rupture of membranes with polyhydramnios, again, you can see where that large fluid volume, break the water, and with that sudden volume loss, you can, again, decompress the uterus and shear the placenta. And any preterm premature rupture of membranes is a risk factor that increases the risk for placental abruption. There is the external or apparent bleeding, which accounts for about 80% of abruptions. The concealed bleeding in about 20% more, although there are a few that will have relatively concealed. The external or apparent, there's obvious heavy vaginal bleeding associated with the abruption. Concealed, you may have very little or no bleeding at all, and the placenta comes off from the wall of the uterus, but all of the blood collects behind the placenta and the membranes are still trapping that blood. And so on ultrasound, you may see a massive clot behind the placenta. Relatively concealed, obviously, is a small amount of vaginal bleeding, but the majority of the blood is trapped behind the placenta in the uterine cavity. 0.5 to 1.5% of pregnancies are affected by placental abruption, and again, this accounts for 30% of third trimester bleeding. It accounts for 15% of perinatal mortality, but be aware that with heavy or significant massive bleeding, it can account for up to 35% of fetal mortality. The hallmark and clinical presentation of placental abruption is painful vaginal bleeding. So again, placenta previa, painless vaginal bleeding; placental abruption, painful vaginal bleeding. Now, having said that, up to 30% will present without pain. We will see a very typical contraction pattern with placental abruption in that you will have tetanic frequent contractions, and someone will walk on the floor, we'll see that pattern, and we're like, that's an abruption pattern. So it's a very classic pattern. On physical examination, you'll see vaginal bleeding. It can be profuse, sometimes light, typically a firm, very tender uterus, non-reassuring fetal heart tones, or actually fetal demise. Oftentimes a coagulopathy will be present, and at C-section you may see a cuvalier uterus, and a cuvalier uterus is where you have extravasation of blood from the uterus into the wall of the uterus, from the uterine cavity into the wall of the uterus. Oftentimes described as kind of ruddy or pink and turning it red. However, most commonly when I have personally seen it, it has presented with venous extravasation of blood along the outer wall of the uterus, and it looks like blue worms across the wall of the uterus with kind of a ruddy background. This is primarily a clinical diagnosis, but when the patient presents with vaginal bleeding, again, the first thing you want to do is an ultrasound, because you don't want to do a vaginal exam in case it's a placenta previa. On ultrasound, however, only 2% of placental abruptions are seen. But again, you want to rule out the previa first. Occasionally in a massive abruption, you'll see that large clot behind the placenta. The treatment usually requires delivery, especially if it's significant bleeding and there's been a significant loss of placental volume off the wall of the uterus, because you will not get adequate blood flow to the fetus and you will have fetal distress. You need to stabilize the mom, prepare for more hemorrhage. Hemorrhage from placental abruptions are often underestimated because of part of the blood being trapped in the uterus. You'll see a coagulopathy in about 1/3 of the women, and even though they may present with massive hemorrhage and hemodynamically unstable, as you begin to resuscitate the mothers and get volume replacement, blood products back, these women are oftentimes preeclamptic and their blood pressures will skyrocket, and then you'll need to deal with that and treat them for preeclampsia. Okay, uterine rupture is another cause of antepartum hemorrhage. We don't see this terribly often. More commonly, we'll see this in the face of a previous C-section. Uterine rupture is caused by weakening of the uterine wall, almost always a prior uterine scar of some type. More than 90% will have a prior scar. Other risk factors are trauma, improper oxytocin use, improper use of fundal pressure, spontaneous rupture from a percreta, multiple gestation because of overdistension of the uterus again, multiparity. That uterus has been stretched over and over, and as that occurs over time, the uterine wall becomes weaker and is at risk for rupturing. Also, a molar pregnancy or choriocarcinoma, that abnormal placental tissue can also grow through the uterine wall and cause a rupture. 0.1 to 0.5% of uteruses with a prior scar are at risk for rupture. With a C-section, the statistic that we quote our patients now with current data, if they want to VBAC, especially because we typically see ruptures more with the onset of labor than we do spontaneously before the onset of labor, but we quote a 1 in 200 risk of rupturing the uterus during a VBAC. Again, it is associated with the weakened wall, either from overdistension, overuse, or improper use of uterotonics, abnormal placenta, and also uterine abnormalities. The bicornuate or the unicornuate uterus can be more commonly associated with uterine rupture. The presentation of uterine rupture is intense abdominal pain plus or minus vaginal bleeding. So again, remember your placenta previa, painless vaginal bleeding, placental abruption, painful vaginal bleeding, uterine rupture, intense pain plus or minus any bleeding. Treatment for this requires immediate laparotomy for delivery, and then all deliveries in the future need to be an elective repeat C-section, because once you've had a uterine rupture, your risk is very high for doing it again, and we will not allow those women to labor. Fetal vessel rupture, we've talked a little bit about this already, but again, this is more commonly with that accessory lobe or with the umbilical cord vessels insert into membranes before they insert into the placenta and branch out, and those will cover the cervical os. And with rupture of membranes or amniotomy, those vessels tear and we see massive hemorrhage. And it may not seem like a lot, but you have to really pay attention to this, because the term fetus only has 250 cc's of blood volume. It does not take long for one of those large vessels to bleed out 250 cc's, so the risk for fetal mortality is high with this also. Laceration of the fetal vessels is from velamentous cord insertion, vasa previa, or a subcenturiate lobe. There is increased risk with multiple gestations. It's about a 1% risk with a singleton, 10% with twins, and up to 50% with triplets. Again, 50% fetal demise with fetal vessel rupture because of the rapidity of the loss of the total fetal blood volume. It occurs in about 0.1 to 0.8% of pregnancies, and the clinical manifestation or presentation is, again, vaginal bleeding, but in this case, no pain, but signs of fetal anemia or fetal distress. Typically, classically, a sinusoidal heart rate pattern. It's kind of a sawtooth fetal heart rate pattern that you'll see. And there are lots of pseudosinusoidal patterns that we'll see that really aren't indicative of fetal distress, but as you gain experience, you will recognize a true sinusoidal pattern, and if you have vaginal bleeding with a sinusoidal pattern, that is a baby that is in serious trouble and needs to be delivered immediately. It's diagnosed by palpation on vaginal exam or by ultrasound. Again, the patient presenting in the second or third trimester with vaginal bleeding, do not do a vaginal exam first, do an ultrasound first. This may be a little bit difficult to see, but if you have that accessory lobe, that's a tip that you may have ruptured some vessels. You can also do an APT test or an APT test, and with this test you collect some of the vaginal blood, dilute this with water, spin it down, collect the supernatant, and add 1% sodium hydroxide, and if it remains pink, that is fetal blood. If it is yellow, that's maternal blood. I have actually never seen this test done. It sounds great, but again, if you've got fetal vessel rupture and a sinusoidal pattern, you're probably not going to take time to do this. You're just going to go straight to C-section and get that baby delivered. Treatment, obviously, is delivery. Non-obstetric causes of antepartum hemorrhage. Again, we touched on these briefly, but I'll go into a slight bit more detail now. Cervical, cervicitis, and during pregnancy, the cervix is hypervascular, very friable, and does bleed easily. I will usually tell my patients on their new OB visit that after vaginal exams, and oftentimes after intercourse, it's not uncommon to have a little vaginal spotting, and I really don't worry about it. You can have polyps of the cervix, and again, cervical cancer, which is really very rare, especially during pregnancy. Bad bleeding from the vagina, from varicosities, lacerations. We had one patient that I remember who actually had a very massive hemorrhage from varicosities, and she and her husband were having intercourse, and they tore into a large varicosity, and she came into the emergency room probably had lost close to 500 cc's of blood, and we had to go in and